Good afternoon. My name is Lauren Footman, and I'm the Community Engagement Coordinator here at the Educational Fund to Stop Gun Violence. And today, we will be having a very timely conversation on coronavirus and its impact, particularly on communities of color. During this conversation, we will hear from great experts around the biology of the virus, its impact on communities of color, and potential intersections for gun violence. Before we go ahead and head into our conversation today, I would like to take the time to thank our National Director of African American Outreach, Kayla Hicks, and our Executive Director, Josh Horwitz, for acknowledging the importance of having this conversation. As more information becomes available about COVID, we are seeing the disproportionate impact this virus is having on communities of color nationally. To do our part, we are launching the End This Together campaign. This campaign will consist of a series of webinars and social media activations that aim to educate and engage our communities with evidence-based information around coronavirus, its impacts on communities of color, and ways we can collectively work together to flatten the curve. As part of this campaign, we are hosting this conversation today to discuss the science behind the virus, the health disparities in communities of color, contributing to the adverse impact, and the connection between COVID-19 and gun violence. To help shed light on this important and timely conversation, we are joined by esteemed panelists. We will have Dr. Devin Horton, the Graduate Diversity Officer for STEM Disciplines at UC Davis. Dr. Horton received her PhD in cellular and molecular biology from the University of Michigan. We will also have Dr. Keshia Pollock Porter, who is a professor of health policy and management at Johns Hopkins School of Public Health, where she also received her PhD. And we will also have Dr. Shani Buggs, who is a postdoctoral fellow with the Violence Prevention Research Program at UC Davis. She also received her PhD in public health from the Johns Hopkins Bloomberg School of Public Health. We will also have some added commentary by our executive director throughout the conversation. Right now, I will hand it over to our first panelist, Dr. Devin Horton, and we will ask you to talk about the biology of coronavirus.
Okay, thank you. So as you mentioned, my name is Devin Horton. My degree is in cell and molecular biology. So even though I do administrative work now, my background is in science and science research. So I'll start off with just telling you about the name. So you might hear coronavirus, COVID-19, that Rona, Roro, whatever. So the official name is COVID-19. The CO stands for corona, right? The VI is for virus, and the D is for disease. So it's COVID, right? Coronavirus disease. And the 19 actually stands for the year 2019, which is when it was first identified. Coronavirus isn't that different from other viruses that have occurred. So you might think of swine flu, which is H1N1, which didn't actually infect swine, but people thought it did, so the name stuck. And you might keep hearing that it's similar to influenza or the common flu. It is in a lot of ways in that it works like most viruses work. The way the viruses work, they're not technically living things, give or take who's talking about it, but essentially a virus needs a host, and that host is your cells. And it does have its own DNA, but you can think of it as not having its own brain. So it kind of has to leech onto something in order to be able to grow and make copies of itself. And so what essentially happens is if someone coughs in your face, which is kind of gross, but if someone coughs in your face, theoretically, in the little spittle that comes out of that person's mouth is the virus. If all of the environment is conducive, what will happen is that virus will get into your mouth or into your eye or somewhere, and then it will find a cell and it will attach itself and inject its DNA into that cell. When that cell does what it does to grow and reproduce, it's unintentionally also making copies of the viral DNA. And that's how you end up with the virus in your body. And that's pretty much any virus, HIV, flu, whatever. The difference is how these viruses impact your personal systems. It turns out that the biggest side effect of COVID or coronavirus is respiratory issues. And what that looks like is your lungs filling up with fluid. And when your lungs don't work, you don't get enough oxygen. And if you don't get enough oxygen, that means your cells aren't getting oxygen. So your liver, your heart, your kidneys, your pancreas, your spleen, your brain. The difference between coronavirus and the other viruses is that it acts really quickly. So for those people for whom it's detrimental quick. So they don't die 5 weeks from now. They die within the 2-week period from the time at which they first got infected. So you contract it the same way you contract any other virus, but the impact on your system is different because it moves so quickly. The other thing that I wanted to make sure to say is that it isn't airborne. There's a difference between airborne and aerosol. So when you think of aerosol, you can think of like spraying your house with Lysol. That's wet. It does exist in the air, but it's not air. When you think airborne, think of mass fires and how you look up and you see smoke, and the smoke can last for days and days and days. That's airborne. Or something we call diesel particulate matter, where when you live in industrialized cities or in urban centers, you can see the smog and the smog. If you ever flew in over LA, it's like a thick layer of nasty fog. That's airborne. The reason that you have to stand far away from people is because actually this virus is aerosolized. So if somebody coughs or sneezes and you're in that space, you could potentially walk through the wet, even though you can't see the wet. It's the other difference between COVID or coronavirus and other viruses is that it's extremely contagious, right? And we don't have immunity to it yet. There's no vaccination. Nobody has a natural immunity. So unless we all stay home, what happens is you just keep giving it to other people, whether you know you have it or not. And it spreads really, 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 really fast because it's incredibly contagious. What else did I want to make sure you all know? Do you all have questions about it? No?
I've heard a number of myths about it. That it's, that it's been intentional, that it spreads with 5G. What do we know about that? Okay.
So 5G, think internet and cell phone. And I don't think your cell phone can give you HIV. That's what I've been telling people. Your cell phone can't give you the flu. 5G refers to electromagnetic waves. And a virus is a virus. It's an organism. And there is no relationship between those things because it just doesn't exist. And if you don't believe me, we've got nothing but time. So go outside and point your cell phone at something and see if it turns into a virus. It doesn't happen. That's not a thing. It is real. I think the reason that people want it to not be real is because we're trying to grasp onto some kind of hope. It's very scary, and our minds start telling us all kinds of things when we realize our mortality is in front of us. But in reality, it is real. I know people at this point who have died. One of my classmates died. And if you reach out into your network, you're probably not that far away from someone who's been impacted. Do not believe people who are showing up on YouTube wearing like face masks and what look like scrubs and calling themselves physicians. So far, the few people who have done that, who have said it's a lie and it's a hoax, are respiratory therapists. We need respiratory therapists, but they are not physicians. I'm accessible. You can ask me questions, whatever you want to know. I'll tell you. I don't bite my tongue. I'm keeping it real. It's not fake. It's a real thing. And the more you gather, the longer we're going to be at home. So think of it like being on punishment. And your parents tell you if you don't be still, you're going to be on punishment longer. That's where we are. I would like to go back outside, so please stay at home. Thank you. Questions, I'm happy to answer.
Thank you, Dr. Horton. Are there any immediate questions for Dr. Horton? Okay, seeing none, we will move on. Thank you. Next, we will have Dr. Pollock Porter.
Great, thanks, Lauren. There's so much I can say to talk about your second point you asked me to speak on, which is really the health disparities. And so I wrote some notes down so I stay on message and I don't digress and talk for 20 minutes when I only have 5. So the 3 things I want to lift up in our time together today is one, really one of the reasons we're here today is the coronavirus is infecting and killing African Americans at a disproportionately high rate as compared to other racial and ethnic groups. Two, the coronavirus has really exposed clearly to those who have not seen it or have not paid attention, the deadly impacts of poverty, racism, and other social factors. Lauren, you mentioned social determinants of health in your introduction, and I'll certainly speak to that. And the third point I want to mention is that if we advance health equity, we really focus on health equity, that is one way that we can help to reduce these disparities, and not just for coronavirus, but also for other health conditions that are affecting communities of color. So let me go back to the first point. So the first thing I said was that we know the data are showing that African Americans are being infected and killed at a disproportionately higher rate than other groups. And I remember one point, there was a narrative that I'm sure everybody heard that African Americans were immune from coronavirus, right? I'm sure people heard that. And, you know, my initial training is in epidemiology, and as an epidemiologist, I will tell you that, of course, if we're not measuring and reporting data by race and ethnicity, it may seem like there's no problem, right? And so, Dr. Horton just gave us a great sense of the biology, and I want to mention that the data, as soon as we started to report the data, as soon as people were showing the data, it was so clear that African Americans are being infected and killed at disproportionate rates. And so just a couple of numbers I want to share just to make this real for people is that we know that of the few jurisdictions that report cases and deaths by rate, that African Americans might be a certain percentage of the population, but the share of the corona deaths is significantly higher. So for example, if you look at data, publicly available data from Milwaukee County, Wisconsin, African Americans represent 26% of the population and 73% of the deaths. Okay, and if that isn't even striking enough for you, we know that data out of Louisiana also shows that African Americans make up just about 32% of the state's population, and they account for 70% of the people who died. Again, so this isn't just in one city and one urban area. We're talking about local data, state data, and national data from the CDC have also reported these trends. In my experience in health conditions I have looked at, there's never been a pandemic that's really brought these disparities so vividly into focus. And so you might be saying, well, why? What's happening? That brings me to my second point. We know that even in the best of times, low-income communities of color, particularly African Americans, Latinos, all Black and brown people overall, are facing daunting medical and health issues. And the coronavirus is really exacerbating the vulnerabilities of these communities. So we know from the data that Dr. Horton just talked about, some of the biology, people with chronic health conditions are being hit harder. So rates of communities or populations with high rates of obesity, hypertension, stress, we know that those are a lot of the communities of color, the communities that we care about, that you are working in. And what's happening there? Well, I certainly want to point to the issues that relate to those social determinants of health, those social factors. So the fact that people of color communities of color tend to oftentimes lack access to safe and affordable foods. They are being impacted by the stress due to things such as institutional racism. They are living in housing communities that are densely concentrated. Let's take a look out of people who are in essential jobs. I'm sure if you've gone to the grocery store recently, you've seen that a lot of those individuals are Black and brown folks. I've been doing some work, I do a lot of work in transportation. I've been working with some transit agencies. People who are driving our buses, people who have to go to work because they're essential workers are riding transit. And these are often the same individuals who we're talking about, African Americans who are being disproportionately affected, who are being exposed, who don't have the luxury that I have today to sit in my office and be part of this conversation, right? And so that's really so important. We'll take a look around at who we're seeing and individuals who are at risk every day because they are providing essential services to us. Finally, the thing I want to mention, my last point, is around health equity. And I really think that this is an opportunity for us to really highlight policies that are going to help to advance health equity. And by health equity, we mean assuring the conditions by which everyone can live the healthiest life possible, no matter who we are, what zip code we were born into, or how much money we make. And in order to do that, we have to take a hard look at the kinds of factors that created these differences, these underlying inequities that are expressed in health disparities. So if we think about things like institutional racism, if we think about affordable healthcare, people not having healthcare tied to our jobs. Look at over 20 million people have lost their jobs recently. The concern is that individuals are not going to have access to healthcare. What's going to happen when they're sick? They're not going to go to the healthcare system. They may, even if they have access, might not even be able to afford the co-pays. So all of these issues are going to continue to exacerbate these differences we're talking about. I also want to mention that I wrote an op-ed recently about paid sick leave. The fact is that a lot of these essential workers I'm talking about don't have regular access to paid sick leave. Yes, Congress made some steps in passing this huge legislation, the stimulus. You know, the benefits there expire December 31st. So even once we get through coronavirus, what's going to happen next year? Individuals are facing the same types of illnesses or other illnesses and have to make what I believe is a false choice of either going to work when you're sick or staying home and not getting paid. If you are a low-income individual, if you are providing for family or other dependents, that's not a real choice to make. So again, let me just sum up my points by saying, you know, we know the data are real. The data are showing African Americans and other communities of color are disproportionately impacted by the coronavirus. We know that the coronavirus has exposed these deadly impacts of poverty, racism, other social determinants of health. And 3, we know that we can address these gaps, these racial disparities, by advancing health equity. So I'll stop there and happy to take any questions or comments.
Are there any initial questions? Okay, we will move along and then we will come back for questions for all of our panelists. Thank you for that salient overview. Now we'll hear from Dr. Buggs on our connection between COVID-19 and gun violence.
Thank you, Lauren. If I don't have my cat in my lap, she makes a lot of noise. So I'm sorry to be talking about such a serious conversation with a cat present. But as Dr. Pollock Porter just illustrated, COVID-19 is exacerbating all of our health inequities and disparities. The fissures were already in existence before COVID-19, and the virus and its impact is just really highlighting and exacerbating all that we know in terms of health equity in our country, and health, not just health equity, but financial security, health and health care, housing, and et cetera. And one of the ways that you really see the intersection between COVID-19 and gun violence is with the violence prevention outreach workers. So individuals who do violence interruption or who work with individuals who are at high risk for violence involvement are in the communities as their primary job in the communities to help mediate conflict, to help calm situations that could escalate to violence. With the coronavirus spread, these workers are now working triple duty. They are still mediating conflicts and still working to support clients through mentorship, but they're also providing supplies and groceries to these individuals and really showing how much there is overlap between gun violence and poverty and unemployment, and comorbidities in health. And then they're also delivering information about COVID-19 and the public health guidelines to communities. We know that in communities that are highly impacted by gun violence, as I said, you have also high levels of poverty, high levels of unemployment, high levels of police contact, high levels of incarceration rates. And through decades, centuries of racism and discrimination, there's a lot of distrust and mistrust in government. And so these outreach workers are working to help deliver services to individuals, but also helping to deliver information and talking about some of the myths that Josh and Dr. Horton we're talking about, because there is a lot of misinformation and a lot of distrust. And as Dr. Pollock Porter said, the individuals who are impacted by COVID-19 are also those who are deemed essential workers and those who don't have access to some of the luxuries that we're enjoying now, being at home, being able to socially distance with ease without having to make the choice between working and potentially exposing yourself to the virus, or staying at home and being safe and healthy. In some places, the violence prevention outreach workers have been deemed essential, and they absolutely are essential, because gun violence has not stopped in many cities. In Baltimore, in Philadelphia, in Milwaukee, in Chicago. Chicago just had 32 people shot over the weekend, 5 fatally. Gun violence has not stopped just because coronavirus is here and is having an impact. And so hospitals are really, and particularly in areas where gun violence continues, are really having to make hard choices between treating gun violence victims and having beds for coronavirus victims. And, it just compounds the complexity of the trauma associated with gun violence, because we're also having to stay at home. So the ability to see loved ones in the hospital, the ability to effectively grieve any kind of death, especially one that occurs from violence, is really, really difficult and hard on everybody. But we continue to see the gun violence. And I think it's too early to really know what all is happening. There are anecdotal reports coming out of different cities, but one of them is, as I said, that COVID is exacerbating the inequities and really heightening frustration, heightening people's concerns about survival and where they're going to be able to find food to support themselves or their families. And so it really is just making everything worse, particularly as it relates to gun violence. We've also seen sharp increases in background checks. And so before whenever there is a natural disaster or some sort of major crisis in our country, we see increases in gun sales. It happened with 9/11, it happened with the 2008 financial crisis, it happened with Hurricane Katrina. And we're seeing that now as well, that there have been sharp increases in background checks, which is a proxy for gun sales. We don't have exact estimates for gun sales in our country. That is data that we as researchers are not able to get, as the data that is not collected. But we've seen estimates have come in that say that compared to last year, when you see background checks and then estimates around gun sales, the estimates are around possibly over 1 million more guns sold in March of this year than compared to March of last year. And what we know that means is that there are a lot more guns in civilian hands because of this surge. We also know that many governors around the country have deemed gun stores as essential businesses. And so while getting your hair cut is not essential, while going to restaurants is not essential, buying a gun has been deemed as an essential part of life right now during this outbreak. And so during this epidemic. And so that is really scary because you have a lot of guns, more guns in civilian hands. And what we know from the research is that increases in firearm sales after events that lead to these kinds of spikes and increase do lead to increases in firearm injuries and firearm deaths. And so there's a lot of concern around unintentional injury from firearms. When you have guns that are owned by people who didn't own guns before, you have concerns around domestic violence and intimate partner violence. And we know from hotlines and survivor supports around the country that there has been a sharp increase in calls around domestic violence. And we know from the research that when you have a gun in the home and domestic violence is occurring, there is a sharp increase in the risk of a death, a firearm injury or death associated with domestic violence. And we also know that there are concerns around suicide. When you have this constellation of factors where you have people staying at home, people being socially isolated, millions and millions of people losing their jobs and not knowing how they're going to support themselves or stay in their homes, there is an increased risk of suicide. And we know that, again, anecdotally, even though suicide is not often talked about in communities of color, over the last 20 years, the highest group that has seen a rate of increase in suicide attempts and completions are Black youth between the ages of 5 and 17. And so we know that suicide is also a real concern for the communities of color, even though it does not get discussed at the same rate as interpersonal violence. So there's a lot that we're going to have to see that will play out as it relates to gun violence and COVID-19. And we need to be vigilant and be supportive of the programs, more than ever, supportive of programs and initiatives that work to stop gun violence from occurring, because this is just, as I said, a constellation of factors coming together that really increase the risk of gun injury and gun death across all categories of gun violence, and particularly in communities of color.
Awesome. Thank you so much, Dr. Buggs, for that great overview. Before we head into our Q&A section, Josh, is there any information or questions or points that you wanted to highlight?
I want to thank everybody, and this is incredible information, but also it just seems to me that this is a tragedy and a tragedy, right? So we have this COVID issue, but we also, it's pointing out the unbelievable health disparities that we have in this country. I was looking at some AP data from Associated Press, and it looks to me like the states with the biggest disparities have the biggest disparity in death in COVID deaths, right? So you have housing disparities, education, income disparities. And if there was ever a time to focus on health disparities, root causes of disease and violence, now is the time. And it seems that with the amount of trillions of dollars that the government is giving out, this issue, the health disparities issue, needs to be addressed in a serious manner. And I'm just going to stop right there, but because I want to hear from everybody else. But to me, it's a clarion call that we need investment now.
Absolutely. And thanks, Josh. And our first question is actually for you.
Okay.
So can you share why the Educational Fund to Stop Gun Violence is getting involved in this conversation around COVID-19?
Well, I think one is because of the intersection that Dr. Buggs described. I think it's clear that we need to understand the root causes of both gun violence and how this epidemic is spreading. I think it would benefit health in general. But we work in a lot of communities in partnership, and we work with groups called community action networks, where we work on policy issues, and we try to work mostly in communities of color and think about policy initiatives that will help violence in those communities. And we're often the partner that brings the data to the table. So where is the violence occurring? What type of violence is happening? What are the age ranges? What are the racial breakdowns and things like that? And so that's a lot of times our role in these discussions. And because of that, I think it was natural for these networks to come back to us and say, hey, we have a lot of questions. Why is it that the communities we're working with on gun violence, why are our communities also suffering from a high rate of COVID? So people from our network came back to us and asked us these questions. We know there's an intersection, but we also thought this was a good opportunity to work with some of the networks that we already work with, like everybody on this call, to help us identify and get information back to the communities that are asking these questions. So that's sort of why we got involved. But listening to this, it's so clear that the root causes are all the same and that we need to work on those things if we ever really want to attain more health equity in this country.
Great. Thanks, Josh. We really appreciate that overview and showing the connection between our work and COVID-19. Dr. Horton, our first question is for you. So you spoke a lot about the structural inequities and how they have impacted communities. Can you share how that may have informed how the myths have been translated to communities, and what are trusted vehicles that communities can gain access to up-to-date information about the virus going forward?
So I think, so there's a history of this country experimenting on people of color, vulnerable populations, that makes our distrust of all government high, right? And it's a double-edged sword, because on the one hand, you need the federal government to step in to sort of mitigate all of the disparities that we're talking about. Like, this is a policy thing. This isn't a personal responsibility thing. But by the same token, you don't trust that same government, because historically, even for those less informed people, less formally informed, they know they have a distrust. They're not sure where the distrust comes from, but they know it exists. I knew that growing up. And so I think that the source of the distrust is what breeds those conspiracy theories, right? And there's always one or two people who are actually educated, but who like to sort of be flamethrowers. And so they go in and they make these suggestions. And if you have people who don't trust the government, but trust people in their community, and the people in their community are spewing misinformation, it's a recipe for disaster. And it only takes one point. So case in point, there was all this talk about Kellyanne Conway making the comment that the 19 in COVID-19 stands. She was hinting that it stood for the 19th version of the virus. And there was some argument about whether she was just a nitwit and didn't know better. But in reality, she knows better. We all know, those of us who are educated and informed know exactly what that 19 stands for. But by saying that, it only takes one person to believe that there are 18 other versions of COVID to then go out and spew that there are 18 other versions. And if we didn't die from those 18 versions, why are we going to die from the 19th? In reality, there aren't 18 other versions. It is for the year in which the virus was discovered, right, when it first appeared. And so I think a lot of the conspiracy theories come from the mistrust of the government. I think it's important that people like those of us who are on this call turn outwards towards the community of people who we know tend to be misinformed, but who trust us uniquely to then correct the record. And so the CDC is a great website. I have a blog. I put the CDC website, anything that they say, I just repurpose it, repackage it into a language that people I love understand. And I put it on the blog. And I always link and say, I didn't make this up. The CDC already said it. I think it's up to us also to make sure that we promote the idea that science is ever changing. And even though I told people in the beginning, it isn't that big of a deal, we'll be okay, that's because had the federal government responded appropriately, it wouldn't have been that big of a deal. We would have been okay. I did not lie. The people who told you that didn't lie. Human error, or deliberate or otherwise, is why we are where we are. We don't have to be here. And that's really important, a really important point to stress to people who are looking for information, because if you said it was going to be okay 3 months ago and we're here, it's real easy to see how they can mistrust that. So we need to promote the fact that science is ever changing. Remember to identify human error in all of this, and try and be people who those people can trust. Because if they trust you, when you then hand them off to, say, a Dr. Bugs or Dr. Pollock Porter, they'll trust them too. So that we're sort of building a network of trust, so that people are not like flying away with all of these conspiracy theories, and they hold fast to them because they don't trust the government. And we really need them to believe the truth, because I need them to stay home because I want to go outside.
I'm with you. I want to go outside as well. Dr. Pollock Porter, the next question is for you. You spoke a lot about health disparities and health inequities. What are some of the short-term and long-term conversations that we should be having with decision makers around addressing these disparities?
Yeah, excellent question. I always tell people, there's hope, there's things we can do. I really think there's so much we need to do around narrative change. Let's talk about these issues. I think COVID-19 gives us a great platform to talk about these issues. You can see this virus does not discriminate. It regardless of what race, ethnicity, gender, income level, we are all at risk if we don't stay inside, right? And so ultimately, it's really important to really change the narrative. And I think this is a time to be talking with our leaders about inequities, about disparities, showing the data. The data are there. The data are clear. I'm not making these numbers up when I talk about the proportion of the population that are African American, as opposed to the proportion of population that are dying from COVID who are African American. These are real numbers. I think we need to talk about them. We need to make sure people understand them and that people believe them. I think the second thing I think is really important is holding our leaders accountable. Right? Like, what are we doing to talk about the fact that we can address these social determinants of health? You know, what are we doing to talk about the importance of income inequalities in contributing to what we're seeing? What are we doing to talk about the importance of educational inequalities to contributing to what we're seeing? Talking about access to healthcare, the mistrust that Dr. Horton talked about. Where does that come from? How do we overcome it? We have to change the narrative. We have to hold our leaders accountable and lift up the policies that are going to dismantle the underlying systems, the institutional racism, the biases that have contributed to where we are now. I'm really hopeful that we can take advantage of this unfortunate situation, really move things forward and say, what kind of world do we want to be in once this is dealt with? Right? Can we have a more equitable society? Is it possible? I believe it is. And I believe we all have a role to play in that.
Absolutely. Thank you for that insight and for those tangible next steps that we can all take. Dr. Buggs, our next question is for you. What is the conversation that communities, advocates should be having with legislators in the short term and long term around gun violence prevention?
Yeah, great question. I think Dr. Pollock Porter hit it on the head. Like this has exposed the failures of our systems. And so we need to recognize that health equity crosses all kinds of categories, including gun violence, including health and access to health, healthy foods, healthy, affordable housing, all of the issues that are arising and being put front and center for all communities right now because of COVID-19, but are particularly salient for communities of color. And I think pressing on the fact that when the government sees that there is a need to respond, there can be swift action taken. And so this is not a question of whether, it's not a question of can we do it? It's a question of do we have enough political power? Do we have enough sense of urgency for all communities to feel safe, for all communities to be taken care of? And so if nothing, one thing that is very clear from the response from the government is that action can be taken. And when there's a recognition that people are suffering and a recognition that action needs to happen, the government can and will step in. And so we need not lose sight of that and keep that front and center, that when you're talking about putting value on people's lives, we need to continue to insist that if the elected officials say that they value every constituent in their jurisdiction, then they need to show it through policy action. I think, I spoke about the rise in firearm sales, or the estimated rise in firearm sales. There needs to be conversation around safe storage. There needs to be conversation and legislation pressed around keeping firearms safely stored at home and what that looks like, and insistent that firearm dealers push, that there are requirements around safe storage and requirements around devices that can keep guns safely out of the hands of those who may be at highest risk for using them in unfortunate situations. And then I think just the continued acknowledgement of how important these gun violence prevention programs are, because as I started with, the individuals who work in this line help to address all of the things that we've been talking about. They help to dispel the myths and help to correct misinformation. They help to address the critical needs of families by helping to provide groceries and supplies and toiletries and sanitizer. You know, we still in this country have, you know, communities that don't have safe drinking water, that don't have safe places to wash their hands. And so the people who are on the front lines, who are working in the communities to help address the issues of gun violence, are helping to address these issues of inequity all around. And they need to be uplifted. They need to be protected. They need to be supported. And we need to continue to think about who are these quote unquote credible messengers who are in the community. And that includes these outreach workers, and it includes people who are doing first response, community-based first response. How do we support them, and how do we leverage their credibility and community network to continue to get information out, and also to help illuminate the kinds of policy solutions that are necessary to address this issue, both in the short term and in the long term?
Thank you, Dr. Buggs. I appreciate that connection and what we can tangibly do moving forward. We're just at time, but I wanted to ask Josh if he had any final questions and or comments that he wanted to respond to.
Well, this has been an incredible conversation, and I know we could go a long time. So what I'm hoping is that as we continue this Together campaign, we'll actually put this video out, and then people may have questions. Maybe we'll be able to invite you guys back to answer some live questions, which I think would be good. My final thought about this is, and this is important right now, is that data is going to matter. Like, we're going to know, we need to know what happened here. We need to know how it compares to communities that are suffering from high levels of violence now. So data collection really matters now. It's something we can't wait to do 6 months from now. And so I'm sure that we should all share that. But I just want, for people who want something to do now is the time to get your health department to make sure you're collecting data based on all the factors, including race. Make sure that we collect that data so that we can adequately look at this and really know what happens, and make sure that we address the inequalities that really cause a lot of the disparities here. So I want to ask a question, because I know we're going long, but I just want everybody to remember how important data is going to be in this discussion.
So thank all of you for participating with us today in our first webinar series of the In This Together campaign. Before we go, we would just ask everyone to remember that we can all do our part to flatten the curve, and that means that we should all wash our hands with soap and water often. We should practice social distancing, and also make sure that we are getting credible information from vehicles such as the CDC. Thank you for joining us.